Hello and welcome. My name is Dr. Andrew Heyman, and I'll be discussing Triad 2 today. Triad 2 is comprised of the gut, the immune system, and the central nervous system. This is a progression from Triad 1, which, as you recall, is a triad that focuses on three important hormones: cortisol, insulin, and thyroid. Triad 1 focuses on the lifestyle-related components of our health with regard to how we eat, how we think, how we move, how we breathe, and all of this translates into energy production. When Triad 1 is imbalanced, people tend to feel fatigued and gain weight. By contrast, Triad 2 expands our understanding of this systems biology approach and moves beyond the interrelationship of three interdependent hormones and focuses more broadly on three bodily systems. In Triad 2, gut, immune, brain, this is an interesting triad because each of these systems have their own sort of intelligence. They're each making decisions on a moment-to-moment basis. The gut attempting to refine what we eat with regard to taking in nutrients or letting go waste. The epithelial lining of the digestive tract with its tight junctions loosening and by turn closing, and having to decide whether or not a protein or a microbe is something that should be tolerated or defended against. And the same is true with the immune system. The immune system being 70 to 80% of its mass lining the digestive tract, ready to make sure that if the gut makes a mistake, if something crosses the epithelial lining of the digestive tract, the immune system is ready and waiting to respond to that threat. And in the same way that the gut is making those moment-to-moment decisions, so too is the immune system attempting to decide self from not self, attack, not attack, me, not me, in a sense. And so this notion of the gut and the immune system not only having to create a sense of security or safety, of being nutritionally replete as well as immunologically balanced, the gut-immune interface is also a broad area where we know components of the gut are actually training the immune system to respond more appropriately. And then finally, the brain. And we think of this in terms of both the nervous system mass in the brain itself, as well as the second brain that's in the gut. And there are as many nerves in the digestive tract as there are in the spinal cord. We call this the enteric nervous system. And interestingly, recent research has shown that the impulses from the gut are more perfusive than the impulses coming from the brain, meaning that the afferent activity of nerve impulse and communication going up from the gut to the brain outweighs or supersedes the amount of information that's flowing from the brain and into the digestive tract. So when we think about having a gut instinct, there is an intelligence there in the way that those nerves are programmed and respond to the local milieu with regard to immune threats or gut-related changes. Certainly, it's been recognized that a wide variety of neurotransmitters are produced in the gut, and that in fact the communication and signaling that is occurring from the gut has great import on how we feel and think. So as much as there's the gut-immune connection, there's also the gut-brain connection. And in fact, like Triad 1, all three are communicating in this one network, this one systems biology approach. And this triad in particular is important with regard to that decision making on a moment to moment basis. So, this is why this triad is labeled as having that primary command and control function. It is about filtering and defense and repair. And unlike Triad 1, which is all about managing energy, uh, this triad is comprised of whole body systems, so this is a major physiologic interface. And what's surprising about this is when you look at the architecture of the gut lining in particular, it's one cell layer thick. You have the epithelial cells lining the digestive tract, and that is the entirety of the separation between the outside world and the inside world. And interestingly, we have this organizational idea, this architecture, repeat itself in the same way that this particular triad has an epithelial lining. So too does Triad 3, cardiopulmonary neurovascular, organize itself around a single cell layer of the vascular tree, the endothelial lining. And it represents architecturally as well as functionally another system of interrelated activities focused on the relationship between the brain and the heart. But at its core, once again, we see a single cell layer as being sort of the area around which all of this activity and communication occur. And then finally, the blood-brain barrier, once again, tight junctions, and we have a single cell layer that is protecting the vital organ of the brain itself. So the body has these major interfaces that each have their own responsibility, but represent a elegance with the way that our physiology arranges itself. There are clearly utilitarian reasons for that, but it also creates a vulnerability with how we exist in the world and where there are potential issues with certain kinds of imbalances or threats. When Triad 2 is functioning normally and we're taking in food and letting it go, the immune system has adequate tolerance and is not overreacting or acting inappropriately, and the central nervous system is making good decisions consciously and subconsciously, and we have an ability to determine what our psychic barriers are, as well as our physical barriers. And all of this is to say that this system is about, therefore, really taking in and letting go, taking in life and letting it go, taking in food and letting it go, taking in immune threats and deciding whether or not we should respond or not. So when Triad 2 is functioning as it should, we have this sense of being kind of organized in the world, and we feel secure, nutritionally, immunologically, psychically. But when this particular triad becomes imbalanced, when there's a breakdown in the gut immune communication, or the gut brain communication, or the gut immune brain communication, and the gut is becoming spastic, dysbiotic, inflamed, or the immune system is losing tolerance and we're marching towards autoimmunity or even cancer, and or we're seeing inappropriate activity within the enteric nervous system or in the brain itself with neuroinflammation centrally, we see the appearance of disorder and unpredictability in symptoms as well as disease processes. And while in Triad 1, typically there's this sort of march towards declining energy and weight gain, In gut immune brain, the total presentation of this particular triad is a little different in that the unpredictability piece becomes primary, meaning that oftentimes the major disease categories contained or related to Triad 2 have this sort of pattern that creates that sense of almost chaos. So if you think of the kind of flaring or episodes of irritable bowel syndrome, that cyclic constipation or diarrhea, or autoimmune diseases that have their unpredictable moments of flares, or the cycling of an individual who's depressed or anxious. These sort of ups and downs that many of the major illness complexes tend to present with. And Triad 2 then is about that issue. And our goal then as a practitioner is to bring calm and order back to these relationships. And on a broader level, if you think about it, when this particular triad becomes imbalanced, these are systems that ultimately feel like they're eating one up inside. Whether it's emotions that are sort of consuming one, or an immune system that is consuming an individual. It's this sort of decline over time that's quiet and leads to these really debilitating illnesses, whether it's an inflammatory bowel disease or autoimmune process, cancer, significant depression, anxiety, or cognitive decline. These are very hard to treat disorders, and there's often overlap in how one system is talking to the other within the frame of gut immune brain. And so there is a biological reality to gut immune brain and the way it's anatomically organized. There is a functional reality and how these three systems develop from fetus on, communicate with each other, and form an integrated unit identified by its ability to think on a moment-to-moment basis to ensure safety and security in the world. But when the forces of life overwhelm these biological processes, disorder arises, unpredictability arises. So there's a tremendous amount of research that's occurring within gut immune brain, and all it takes is a moment to even just Google gut-brain axis or gut immune axis or brain immune axis, and it's easy to find dozens and dozens, if not hundreds, of studies on the relationship between these three systems. So critical for keeping us safe in the world. So the characteristics of Triad 2, this notion of being able to take in and let go, this cell level intelligence, below cognition, in a sense, that the gut is making decisions, the immune system is making decisions, and so too is the enteric nervous system, all of which eventually influences how we feel and behave. And it's this sense of self-knowing. I think that in many ways, this idea of what is best for us as an individual from a systems perspective is often driven from within this particular triad. What is best for me nutritionally? What is best for me immunologically? What is best for me psychically? Do I know myself? Do I know myself in the world? And how I operate and function, what my needs are, and when the sort of real and functional borders of gut immune brain break down and we lose that capacity to remain safe, that's when the imbalances of gut immune brain begin to arise. We want these calm borders and boundaries. We want to remain grounded and centered in the world, in a sense. And this particular bodily system allows us to do that effectively. So gut, immune, brain. It's a wonderful triad. It's incredibly complicated. It's amazing how much research is occurring from the systems biology perspective. And over, we see the importance of the relationship between these three systems, physiologically as well as clinically. As I mentioned before, the gut is about absorption and elimination. The immune system focuses on defense and repair, and the brain itself being command and control. So the gut, a single epithelial layer, focused on the beginning processes of metabolism and transformation of biochemicals. It provides a structural defense as well as a training ground for the immune system itself. It's where the innate immune system can be triggered. It's also where B cells and T cells can become activated in their stance with regard to immune tolerance and whether or not the immune system will learn to attack proteins or antigens on food or viruses or other biological threats. In the rest cycle of the immune system, it's very important for repair. So we want inflammation to resolve itself and be able to induce growth and transformation. It's also critical with regard to cell communication, not just within the immune system, but acting as a mediator between other bodily systems. And then finally, the brain in terms of cognition, executive functioning, memory, but also on the mood-related side with regard to emotions, and then finally, it being the central control of physiology. So here's a model that links Triad 1 with Triad 2. And now we're getting into a concept of stacking. Of course, we are these complex beings that all of the triads, all of the systems are functioning simultaneously. And not only is there direct communication within a triad, but there's communication across systems, across triads, that these functional domains that we've identified have resonances up and down all of the bodily processes. And this is one model that's been articulated that I think really begins to show a set of relationships that I think is really important. And this displays the impact that stress has on gut, immune, brain. So Triad 1 on Triad 2. In the upper right-hand box, we can see activation of the HPA axis if there's some sort of perceived threat. And there are two stimuli that are produced. The first from the sympathetic nervous system, where we have heightened adrenergic tone, and this changes our physiology in the moment because of the quick activation of the sympathetic chain in the way that it influences all sorts of bodily processes. But one target organ of sympathetic tone is the digestive tract, and you can see that in the way that these efferent fibers will trigger enterochromaffin cells in the gut, which then release peripheral corticotropin releasing hormone, and this has a direct effect on tight junctions in the gut, but it also in turn will stimulate activity of mast cells. And here is that link that I would point out between cortisol and atopic illnesses. So it turns out that when we're under stress, mediated through CRH, we have elevated histamine release, which has been linked, of course, to Th2 dominant illnesses. So allergies, eczema, and asthma. And this kind of histamine response is occurring in the gut and is in part responsible for establishing the predisposition of leakiness in the gut, because that's what histamine does, is it creates leakiness, and therefore increases the likelihood of gut immune complexes being formed, a la food immune proteins. And so stress, therefore, through direct and indirect mechanisms, both through the release of CRH as well as cortisol's direct impact on the tight junctions of the digestive tract, can create permeability. And I would point out then, as we've talked about in the last 2 weeks on Triad 1, that when an individual is under stress, we need to recognize that cortisol is a catabolic hormone. And if left unchecked, if there is no antidote to that, bodily tissues begin to break down. We talked about this with regard to the model of neurodegeneration and the ways in which the brain alters with regard to states of stress, but so too does the gut lining. And that is, of course, another link between Triad 1 and Triad 2. So inasmuch as cortisol has an impact on gut permeability, so too does it shift the immune system in a heightened state to being Th2 dominant with elevated histamine release, but also cortisol's direct impact on the brain and the neuroexcitation and inflammation that occurs as a result, as well as its modulating effects on the immune system. We know that Th1 activity becomes suppressed under states of high cortisol. Mast cell activity is triggered, and when cortisol levels conversely are low, we have elevated Th1 activity and a predisposition towards autoimmunity. So all of these changes can be occurring simultaneously under stress. Brain-related changes, immune system changes, but now gut-related changes. And once we have a heightened state of permeability, the likelihood of antigen presentation, where antigen-presenting cells and dendritic cells are identifying protein immune complexes, food-bound molecules that will trigger the T and B cell activity on the other side of the gut lining, which leads to not only immune activation with production of IgG antibodies or IgE antibodies, but also systemic inflammation, which can be sensed by the brain itself. And so those afferent signals that are pulsing up from the gut to the brain are alerting the brain that there is abnormal activity in the gut, mediated both within the enteric nervous system as well as through that inflammatory response. And so we know that, in fact, actually changes behavior. It can influence mood. We know that when there's gut inflammation, people are more predisposed to depression and anxiety, even memory loss, poor coping skills and strategies. So all of that can be influenced or heightened in the setting of stress. So what we're beginning to articulate then is the relationship among these three bodily systems. We begin with the microbiota, which exists in the gut, which has certainly received a lot of attention in that the amount of DNA that we contain as an organism, most of which, 90% of which, is not our own, but related to the microbiome itself, which is not only harbored within the gut, but also we now know on the skin and the lungs and the blood supply. But this notion that bacteria can confer great benefit to our health, that we are codependent in that regard. But conversely, when we have abnormal populations or types of bacteria, this label of dysbiosis has arisen over the past couple decades. And certainly the idea that this can be influenced by the administration of probiotics or even prebiotics or other factors that can remodulate the microbiota in the gut, which we have learned is important for breaking food down, training the immune system, crowding out pathogens, and acting as an energy source for the body. And this related notion of intestinal permeability, which is not always a bad thing, of course. The gut needs to get it right with regard to what it's letting in and what it's not letting in. But when we have that leakiness, that colloquial idea that the gut is making mistakes, it ends up being a trigger, in a sense, where the immune system is waiting on the other side. And from the functional perspective, this notion that food is a major factor then for modulating and inducing a reaction within the immune system. And so understanding what those food triggers are in terms of further refining our ability to personalize care with patients, that we start with the broad notion of what's healthy for the individual, but then we can also begin to focus our nutritional therapy based on food panels, for example. I would suggest, though, that one should look pretty deeply at the science of these food panels that are available, especially the IgG food panels, because a lot of them, I think, are relatively inaccurate in this regard. There are some that are good that I use in my own practice, for example, which we can talk about in cases. But I think many of them are unreliable in their ability to identify true triggers, as opposed to, in fact, the presence of elevated IgG, which signals immune tolerance. The intraepithelial lymphocytes, these are white blood cells that begin to accumulate at the end of the microvilli of the gut lining. This is a signal that the immune system is becoming reactive to some sort of threat. In the old days of pathology, when a biopsy of the gut lining was taken, they could count up the amount of these accumulated cells. And if a threshold was reached, I think it was 20 or so, that were beginning to crowd the end of the microvilli, it was thought that that was a strong indication of inflammation that was developing in the gut. Additionally, we have upregulation of antigen-presenting cells. This is the set of initiating processes that triggers the immune system in the way that it's recognizing antigens that are in the gut. And there's a set of interrelated immune processes beginning with upregulated antigen-presenting cells. That is the secondary step of immune activation. And these cells are looking for proteins and immune complexes that will further stimulate a Th1 mediated response, meaning a T cell and B cell activity. So the barrier of the intestines, it's our largest mucosal surface, and it is our major interface with the external world, and we've talked about a number of its key functions. The mucosal lining itself provides a physical layer of protection. It's made of mucin. Mucin production is upregulated by probiotics, and not only can stress begin to compromise the lining of the digestive tract, but so too can other factors such as medications and drugs, diet, environmental chemicals, gut flora imbalances, and a genetic predisposition. So this is a short list, but an important one. Stress, of course, is located to Triad 1. Diet is Triad 1 and 2. Environmental chemicals is Triad 4 with liver, lymph, kidney. Gut flora would be Triad 2. And a genetic predisposition, which locates across all of the triads. But this notion that there are a variety of threats that can break down the gut lining and increase gut immune activity, we need to recognize and directly address. So the microflora participates in immune modulation, control of pathogens. It helps with breakdown of nutrients, and it helps with absorption and metabolism. It induces immune tolerance, and important for hormone regulation as well. But when dysbiosis arises, when we have an abnormal type or amount of pathogens in the gut, this can lead to a variety of abnormal responses, including enhanced gut permeability. These organisms help to synthesize butyrate, which is the energy substrate that's important for the GI lining. Butyrate is also important for any cell lipid bilayer, very critical for ensuring a normal cell membrane. Cell membranes and mucosal linings can become damaged because of inflammation. And in particular in the gut, if we have a lack of certain kinds of probiotics or good microbiota, we just don't have the engine to produce butyrate, which is a short-chain fatty acid. Dysbiotic organisms contribute to the deterioration of the intestinal lining via yeast, bacteria, and parasites, and it protects the cells of the intestines from abnormal growth. As I mentioned before, the epithelial lining is one cell layer thick, mediated by tight junctions, occludin and zonulin, which we can now measure. And normal levels of lymphocytes and epithelial cells help maintain tight junctions, and then as they accumulate at the edges of the microvilli, damage occurs. Lymphocytes themselves, which congregate within the gut lining as well as just on the other side, can indicate all sorts of abnormal immune activity. Food can be an issue, stress, toxins, as well as pathogenic exposures. Allergens can do this too, and we know that you can have excess mast cell activity, again, especially in the setting of chronic stress states with elevated cortisol. The major histocompatibility complex, MHC, class 1 and 2, are important for the body to recognize self from not self. These are encoded genes, or genes that encode glycoproteins that bind to peptides, and this is how T cells recognize whether or not the immune system remains tolerant to threats or has a predisposition to autoimmunity. And there can be a number of genetic variations as well as ongoing physiologic changes that can induce the immune system to become intolerant to what otherwise should be benign exposures. This is the staining of the intraepithelial cells along the microvilli, and what this shows is in fact a model that was derived out of a diabetic population, that in fact diabetics tend to have an overaccumulation of intraepithelial lymphocytes, and it's thought that the gut actually plays a large role in the development of inflammation, which also has been shown to underlie insulin resistance. And so part of this is HLA, class 2, with regard to the body recognizing self from not self. Diabetics tend to have a component of autoimmunity that heretofore had not been recognized, and that immune intolerance has to be part of the thinking around the development of insulin resistance in type 2 diabetes. And so here again, we have another relationship between Triad 1 and Triad 2. Triad 1 in particular, or I'm sorry, type 1 diabetes in particular, um, being an autoimmune disease, um, is now known to have a genetic component that overlaps with immune intolerance along the HLA sequencing, but that in fact it's been shown to be responsive to managing the diet and decreasing gut immune inflammation. Um, so there's an important interplay between intestinal microbial environment and mucosal immunity, and a significant role in autoimmune and metabolic conditions, including type 1 diabetes, meaning that if you can control the gut immune interface as best as possible, you have a chance of also reducing that immune intolerance that underlies not only type 1 diabetes as a model, but any autoimmune process. And so we are recognizing more and more that it may very well be the primary initiating factors for many autoimmune diseases begin in the gut lining itself, which makes sense because that's where most of our immune mass lives. It's where it's trained, it's interacting with the gut and the microbiome, and more, the model is being validated as we understand some of the details. Um, Resistant starches, in particular, have been shown to play an important role. Um, these are super sugars that are now on the market and feed the gut lining, feed the enterocytes, and allow the blood glucose response to be level and prolonged, where we don't have an insulin spike. And so that's part of controlling not only the stability of blood sugar in the bloodstream, but also in the way that food triggers the immune system. And so resistant starches have been shown to feed the gut lining, help the immune system improve its tolerance, stabilize blood sugar. This is something that you can purchase as a powder, goes under the name UCAN, but also boiled potatoes that are cold, or even slightly green bananas have high amounts of resistant starches. So this is just a model of the way in which altered mucosal activity can lead to increased permeability via dietary antigens, and we have an activation of antigen-presenting cells, which then trigger a T cell and B cell mediated response. So the immune system is becoming autoreactive and immune intolerant, and one of the targets of that intolerance then can be the pancreatic beta cells. And so there's destruction of the body's ability to produce insulin. This is the model then of how leaky gut can lead to a predisposition towards type 1 diabetes. Think of this then as a model for many autoimmune diseases as well. So dendritic cells, there's a lot of research on toll-like receptors, which are a component of dendritic cells. These are part of the antigen-presenting cell response system, and toll-like receptors are part of the ways in which these cells dock antigens, and depending on the type of docking that occurs and the type of receptor that's present, we can have either immune tolerance or intolerance. So, for example, friendly flora induce toll-like receptor 4 and reduce food antigens action, toll-like receptor 2 is enhanced and improves gut barrier permeability. So there's some work at which toll-like receptors can be triggered or modulated through food as well as dietary supplements, but we just don't have good treatments for that yet. So the GALT, which is the gut-associated lymphoid tissue, is very important with regard to understanding the localized immune response in the digestive tract, and this is highlighted through secretory IgA. This is a B cell produced Ig antibody, and we can measure secretory IgA in the gut lining. We know that one of the major factors of reducing integrity of the gut immune interface via the GALT is actually stress. Stress will lower IgA, which is our specific immune antibody for protecting the gut lining itself. And so if an individual has low secretory IgA, they tend to be more susceptible to pathogens in the gut. So this is another way that stress can influence gut immune integrity. So here are some endogenous substances that influence the intestinal epithelial cells. Histamine, as I mentioned, which is produced by mast cells, and then a variety of cytokines and inflammatory proteins that can also influence gut activity. So for example, leukotrienes, TNF-alpha, IL-4, even serotonin, which has a relationship to the immune system, but especially through its triggering of spasticity in the gut. We know that excess serotonin production underlies inflammatory bowel disease as well as irritable bowel syndrome. And then finally, mast cell proteases and platelet activating factor. So factors influencing intestinal flora, there's a long list, and we go through this as part of the discipline of a workup of a patient. We want to know, have they been on certain medications that degrade the gut lining? Is there excess sugar intake, which can lead to dysbiosis and yeast overgrowth? Do they consume water, for example, that has not been treated effectively? What are their food sources? Have they been exposed to toxins such as alcohol or heavy metals? What is their history of stress? And do they have a history of allergies too? So this is a model of how the gut functions with regard to gut permeability. We can see, beginning with number 1, a wide variety of factors that can influence the integrity of the gut lining. And in the lumen of the gut, you can have formation of immunomodulatory as well as inflammatory fragments that are getting through the tight junctions in between the epithelial cells. So this activity then is the primary trigger for passage of dietary peptides and tight junction proteins that, as you can see in step 5, begin to encounter antigen-presenting cells. And so these absorb the antigens, their toll-like receptors are triggered, and we have docking between APCs and T cells, which then communicate with B cells, and you have a B cell mediated antibody response, which not only is responsible for formation of IgG and IgM and IgA, but also direct antibody production against the tight junctions. So in the lower right hand box, you can see the final comment, which is important to note, that you can have cross reaction with different tissues and induction of autoimmune disease in different organs. So this is the model for type 1 diabetes, but again, a variety of autoimmune illnesses. So our job as practitioners is to restore a normal immune activity, induce immune tolerance, improve a dysbiotic environment, decrease the exposures that are leading to this in the first place, try and identify any food sensitivities that the individual may have, and hope that we can unwind an immune system that has learned to respond inappropriately to a variety of food triggers. There's also the immune brain interface. We know that there's direct communication between various immune cells and the brain. This notion of neuroinflammation has become a very hot topic. We've mentioned this before in the setting of stress, but neuroinflammation can be induced by a variety of processes, including biotoxic exposures to chronic infections, a moldy environment, as well as additional environmental triggers such as heavy metals and chemicals. And this then begins to form the basis of the relationship between the innate immune system in particular and the central nervous system. And this all is occurring outside of the adaptive immune system. So we're moving from a model of B and T cell activation that I just mentioned into a model of neuroinflammation that's driven by the innate immune system, which is the unthinking side of the immune system. It does not have memory, but for some people, when the innate immune system is activated, they can remain perpetually inflamed. And the target of that inflammation is the nervous system, that with elevated markers such as TGF beta 1, C3A, C4A, there is a direct impact on nerve activity with hyperexcitation, inflammation, and ultimately atrophy and degradation, both peripherally and centrally. So this is an important model of how the nervous system communicates with the immune system, this bidirectional relationship, somewhat mediated through the stress response, but also through sympathetic efference. And so this was a breakthrough in how we understood the relationship between the nervous system and the immune system, that in fact, when we're under stress, cortisol is modulating certain activity in the immune system, as we've mentioned. When cortisol levels are high, individuals are Th2 dominant, mast cells are triggered, but also the input on the sympathetic nervous system side with prolonged exposure to epinephrine and norepinephrine can actually trigger over time excess IL-6 and TNF-alpha and CRP release. So this makes sense that with prolonged stress, not only is there a predisposition to low cortisol output, which can further enhance Th1 activity and autoimmunity, but also the sympathetic nervous system with chronotropic dominance and sympathetic drive can further enhance inflammation in the body. So this neuroinflammatory process that we now know stands at the center of a variety of illnesses is so critically important to understand. So a patient who's under stress, who has elevated sympathetic tone, they tend to have abnormalities in the immune system as well, which in turn affects the brain, which we've talked about with regard to brain-related inflammation. This occurs with stress, but it also occurs with food exposures, environmental chemicals, pathogens, mold, so on and so forth. And so this is a very important connection that I want you to understand. There's also a relationship between hormones in particular and the immune system. Hormones tend to be quite regulatory on the immune system, not just cortisol, but also reproductive hormones as well as thyroid, and in turn activation of these immune cells, as well as maturation of cells in the thymus and in the bone marrow, in turn influences how the immune system behaves over long periods of time. And so, from a clinical perspective, more and more I've come to appreciate that because of a bidirectional relationship and how the immune system in particular stands in the center of a lot of chronic illnesses, it's not uncommon for hormones to be measured as abnormal in the setting of chronic inflammatory responses. And I think that oftentimes some of us might struggle with trying to balance hormones. And if we're unsuccessful with that, um, it's often because of the underlying inflammatory response that we haven't addressed yet. This slide is meant to remind you of just the maturation of immune cells in the innate and adaptive side of the immune system. The adaptive is at the top with B cell and T cell production, and then at the bottom we have innate immune activation, again, the unthinking side of the immune system. Here is a model for how we understand uh, T cell activity and the ways in which the adaptive immune system organizes itself along key activities with regard to sort of the dominance of specific cells within the adaptive side of the immune system. And that's primarily on the right, which is Th1 and Th2. This is part of the older model of Th-mediated illnesses. Again, Th2 really focuses on allergies and asthma, Th1 autoimmunity, but there is a new player, which is Th17, which has also been identified in autoimmunity. And here is the link between the innate immune system and the adaptive, primarily driven through TGF-beta 1, which is a transcription factor. You can measure it in the serum. You will find that it is often elevated in the setting of a chronic inflammatory response, usually due to a biological exposure to chronic infections or mold. And so when TGF-beta 1 elevates, not only does it signal an activation of the innate immune system, but TGF-beta 1 can drive Th17 activity in the peripheral tissue. And when Th17 activity increases, we have a predisposition to autoimmunity. You can also measure Treg cells, and these are mostly derived from CD4, CD25, which you can also measure too, which induce immune tolerance. And you want to increase Treg cell activity, but this is often directly suppressed through TGF-beta 1. And so there's often imbalancing on the left side of this display, where we have triggering of the innate immune system mediated through an elevated TGF-beta 1 and the suppression of Treg cells. And so you want to reduce the exposure of the individual if, for example, they're living in a moldy environment and they're having symptoms of neuroinflammation. And we can measure this then through serum markers of CD4, CD25, TGF-beta 1, and so on and so forth. Here is what happens in the brain itself, because under states of neuroinflammation, we have microglial cells that become active. These are the immune cells of the brain. This is what underlies brain inflammation. And the challenge that occurs when we have triggers or exposures that is turning on systemic inflammation, which in turn is affecting the brain itself, that when microglial do become activated, they release their neurotoxic factors, and there's a direct localized insult to neurons nearby. And when these neurons are damaged or die, they release their own cytokines and proteins that in turn further stimulate microglial activity. And so we have this kind of self-perpetuating process. As a result, then, there's activity with regard to dendritic retraction, pruning, and atrophy that can occur in the brain as a result of neuroinflammation as the neurons are trying to protect themselves against excess microglial inflammation. So there is a functional relationship between the gut and the brain. I've talked about the enteric nervous system, enterochromaffin cells, and there's also tryptophan metabolism in the gut, all of which are important. Tryptophan metabolism is responsible for production of serotonin, which then makes its way to the brain. The brain senses this and utilizes the substrates of these neurotransmitters for its own brain-related activity. And there's an interesting relationship then between the gut and the brain, and this is signaled through a model of irritable bowel and inflammatory bowel disease. So in irritable bowel syndrome, stress increases the HPA axis, and both branches of the autonomic nervous system, cortisol will suppress Th1 and shift towards a Th2 dominant response. This is what we see in irritable bowel with spasticity, constipation, and functional bowel disturbances, but no immune response per se that is typically measured, although we know that irritable bowel is a Th2 dominant state. Conversely, in inflammatory bowel disease, where the individual is systemically inflamed, not just in the gut, we see a blunting of the stress response. Remember, inflammation occurs on a teeter-totter relationship with stress. So we see corticotropin releasing factor lower, which leads to diminished cortisol and norepi release. Again, the individual is moving towards a Th1 dominant state, and this occurs both in the gut as well as systemically. This is the definition of an autoimmune disease. But finally, and this is interesting, if you have a irritable bowel patient who has chronic stress and therefore their cortisol levels are low, you can shift an individual who can have an irritable bowel presentation, but that in fact they can be Th1 dominant. And so they begin to reflect an inflammatory bowel disease. What this means then is that you can go from a functional gut-brain disturbance of irritable bowel and with chronic stress predispose that individual towards more of an inflammatory bowel disease stance with an activated Th1. And so this, we think, is part of the progression of individuals who start with functional physiologic disturbances within gut immune brain. But again, this is highlighting the impact of stress and how it can modulate the immune system to become more autoimmune. And so if you have a flattened cortisol curve in the setting of a functional issue like irritable bowel, you have to be hypervigilant to that. And that, in fact, this highlights the importance of looking at those patients more keenly. We talked about this in Triad 1 when you had an individual who had hypothyroidism, blood sugar imbalances, and a flattened cortisol curve. That can predispose individuals to Hashimoto's. The same is true in the gut. So here is that model. You can see on the left-hand column, this is irritable bowel syndrome with acute stress. Cortisol levels go up. They become Th2 dominant. There's tryptase and histamine release. And so we have a suppression of Th1. This is the classic presentation of someone who's under stress with a spastic bowel. They usually have an overlay of depression or anxiety, all of which makes sense. We talked about how elevated cortisol is often labeled as a treatment-sensitive depression. Depression and irritable bowel often overlap, and so this model shows the underlying stance of the immune system as it relates to these metabolic forces. Conversely, when we have an inflammatory bowel disease and the person is under acute stress, because of the stance of the immune system and they're significantly inflamed, they have a blunted stress response. and they are more predisposed to abnormalities with their ability to produce cortisol as a result because of the teeter-totter relationship. Cortisol levels are by definition typically lower, which allows for a Th1 dominant state with higher levels of IL-6 and IL-1 and TNF alpha, and therefore suppression of Th2. So all of this begins to make sense in the context of Triad 1, Triad 2. And then a progression within Triad 1, we go from acute stress to chronic stress. We have a further blunting of cortisol, and this therefore flips the irritable bowel patient, and it makes them more predisposed to excess inflammation and autoimmunity. So you are progressing these individuals and you're making them sicker. And you can see how not only are they more inflamed, but in fact you can trigger pain centers in the brain, which sit very closely to the stress centers. So this then becomes the model of the irritable bowel, chronic fatigue, fibromyalgia, stressed, depressed patient that presents to the practice, and the standard of care is an antidepressant with exercise. And you can see how these patients are far more complex than that. They are a blending or stacking of Triad 1 and Triad 2. This is a beautiful model then of that systems biology approach of what's really underlying these patients in the way that they express their symptoms and how they organize their complaints along a Triad 1 and a Triad 2, and how these systems interact with each other. Here's the neurodegenerative hypothesis of depression, and this is a model of how inflammation in the gut can influence mood. And that is to say that there is an enzyme called indoleamine, which is responsible for the breakdown of tryptophan. And it will convert tryptophan into kynurenine, and actually the preference is to convert further into quinolinate. Quinolinic acid, we know, is neuroinflammatory. This is, while it's a compound that's produced in the gut, it will directly affect the brain. So we have neuroexcitation and inflammation. And what it's doing is it's shunting metabolism away from serotonin production and into quinolinic acid. So when we have stressors in the gut, whether it's actual emotional stress, food intolerances, chemicals, biological exposures, we can induce indoleamines. And when that occurs, there is a significant shift in serotonin production. So this becomes an additional model for how our mood can be influenced from the gut immune axis within Triad 2. So gut inflammation and serotonin, IDO degrades tryptophan, and N-formyl kynurenine is metabolized ultimately into quinolinic acid. And so we know that obese individuals have low serum tryptophan, and that in turn also, not only does it underlie obesity with regard to that immune activation, but also with low tryptophan, that means that individuals often crave comfort foods. So when the gut is inflamed, we tend to want carbohydrates, which of course further worsens the predisposition towards obesity. So here are all the factors in the gut that will either stimulate or inhibit normal digestive processes. This is just a quick review. And antibiotics, we can get yeast overgrowth of candida in particular. Stress will do it. Medications will do it. Chemicals will do it. And when candida takes hold, there is fermentation, and yeast in particular produces acetaldehyde. And there's quite a body of literature on acetaldehyde with regard to a variety of systemic symptoms being driven by yeast accumulation in the digestive tract. This idea of candida overgrowth has been around for a long time, but in fact, there is some good evidence to suggest when it occurs, people certainly systemically don't feel well. So a lot of this is mediated through acetaldehyde itself, and not just merely from the presence of excess yeast. So what is acetaldehyde? It's a chemical byproduct of alcohol yeast metabolism. Other sources are fuel exhaust and cigarette smoking. They're best known as fragrances, but they're toxic to cells and tissues and must be broken down by enzymes in the body to acetic acid. If enzymes can't keep up, it travels in the bloodstream and accumulates in tissue, brain, spinal cord, muscle, liver. People do not feel well when acetaldehyde levels are climbing in the body. And again, a lot of this is due to yeast overgrowth. So acetaldehyde is ultimately produced because of decreased oxygen, decarboxylates pyruvate to acetaldehyde and ethanol. And so once the acetaldehyde is produced in the setting of yeast, it is metabolized in the liver and creates toxicity when excess formation occurs. And we have a displacement of the NADH-NAD ratio. And this is critically important, particularly for the nervous system, because NAD plus is a major energy substrate. And so what happens is, just like butyrate is a substrate in the digestive tract, NAD is a substrate in the brain. And when NAD pools are low and there's lowered production, therefore, of ATP, you have cognitive decline and mood-related disorders as a result. There's a strong link then between low NAD and loss of memory. And so it's critically important then to try and raise NAD levels in the brain, which in turn will raise ATP production. And acetaldehyde in particular interferes with this. So when we have an elevated NADH to NAD ratio, it increases the lactate to pyruvate ratio, which means that there's more lactic acid being produced systemically. The pH level of the body is dropping. And when that occurs, enzyme systems are breaking down in the liver and the kidneys, and the body is having a much harder time detoxifying. There's also recent data to link lower pH with insulin resistance and obesity. So it's critically important to ensure not only adequate NAD pools by eliminating yeast, and I'll talk about some methods of raising NAD, but also ensuring that your patients have a pH that is above 6.8. We talked about this in Triad 1, but it's also important in the setting of Triad 2 because changes in the gut can also induce a lower pH. So it increases ratio of hydroxysteroids to ketosteroids, decreases galactose tolerance, which is conversion of galactose to glucose, and it alters amine metabolism. The first one I think is the most important, which is offsetting the lactate to pyruvate. So what happens is there are citric acid cycle changes, the Krebs cycle, in its ability to produce ATP. So there's inhibition of fatty acid oxidation, which inhibits gluconeogenesis. So this forms the basis of both the sort of lack of ATP production at the mitochondrial level, but also the blunting of efficient glucose disposition. And so this is that relationship where as the individual is becoming more acidic and offsetting their NADH-NAD ratio, it's inducing changes in the body's ability to produce energy. So the side effects of acetaldehyde, it depletes B1 and B3, stops the ability of acetyl coenzyme A to trigger energy production at the Krebs cycle level, and reacts with dopamine in brain to make a phenolic chemical called salsolinol, and reacts with serotonin to form beta-carboline. So this is part of the predisposition of cravings and reward that can underlie addiction. So this is critically important that you see even just in yeast overgrowth where patients will talk about addictive behaviors, and it's important therefore to assess whether or not they have yeast overgrowth and treat the gut. So the effects of acetaldehyde, it can induce chemical sensitivities, headaches, foggy head, impaired memory, limit neurotransmitter production, underlies mood disorders, addiction, and cell damage. So you can't underestimate what dysbiosis, yeast overgrowth, acetaldehyde production can do in terms of decreasing ATP output, uh, decreasing pH, and causing all sorts of systemic symptoms, and you can see a lot of this is related to the brain. One of the other consequences of breakdown in the gut, in addition to a loss of immune tolerance or overproduction of acetaldehyde, there's a recognition that there are additional immune factors that can be produced in the gut that can have a variety of sort of damaging consequences in our physiology. And so the model of this are lipopolysaccharides. These are long carbohydrate molecules and fatty acids. It's considered an endotoxin and is the structural part of bacteria, which serves as a barrier to exotoxins from other organisms. The intestines and liver should break down lipopolysaccharides and eliminate them. But when the gut becomes leaky, especially under chronic stress, we have an overabsorption of these endotoxins. And as a result of elevated lipopolysaccharides, we see an excess release of serotonin from platelets, which can cause vasoconstriction, and in turn, excess serotonin not only causes spasticity in the gut and vasoconstriction, but also decrease in mitochondrial energy production. So lipopolysaccharides have been measured in a variety of populations, including endurance athletes. It's actually been well studied as a model of stress in the gut, and it's believed that this endotoxin in particular is the major cause of why individuals can become so sick with endurance activity. So when LPS is released into the blood, it's associated with the increase in cytokines and can lead to fever and shock. It's been shown that runners who take a long time to finish a race have a greater level of endotoxemia, and furthermore, endotoxemia and increased cytokines may lead specifically to GI pathology. That endotoxin entry into the port of circulation may lead to grave effects such as portal vein thrombosis via local hypercoagulable environment, meaning that when you have prolonged stress from endurance activities, for example, with an excess release of endotoxins, it can have a wide variety of consequences. And it's not just in endurance athletes, though, where we have an excess production of lipopolysaccharides. We see this especially in metabolic syndrome patients and in vasculopaths, as well as those that have significant gut immune pathology. It turns out you can now measure lipopolysaccharide, and I think it's really important in patients, especially with chronic stress. So this is a model of what's happening with the bacterial lipopolysaccharides, which is inducing a cascade of intracellular protein complexes, which turns on gene transcription that ultimately induces production of cytokines and interleukins that initiate an inflammatory response. The idea being that lipopolysaccharides are very potent with inducing inflammation. And the effects are wide-ranging. Not only do we see stimulation of TNF-alpha and IL-6 and elevated white blood cells, but there's a great impact on the cardiovascular system with damage to the endothelial lining. We also see a triggering of the immune system, as well as impact on insulin signaling and thyroid function. So gut inflammation via elevated lipopolysaccharide clearly affects Triad 1. So in the same way that stress can modulate gut immune brain can modulate Triad 1, but we also see alterations in tryptophan metabolism, and as I mentioned before, induction of indolamines and expression of quinolinic acid, which is damaging to the brain, decreased melatonin, which again is a Triad 1 impact, and then decreased glutathione pools. so the body has a harder time detoxifying, which in turn leads to excess lactic acid production. So lipopolysaccharides have a very strong impact up to Triad 1, down to Triad 3 with cardiopulmonary neurovascular, as well as a direct impact on Triad 2. So, as I mentioned, the gut is a engine of inflammation that can affect insulin resistance. I talked about this with regard to the impact on autoimmunity that underlies not only type 1 diabetes, but likely type 2 diabetes. The same can be true of lipopolysaccharides. And this is mediated through toll-like receptors, which can damage insulin receptors. So here's a study, 516 men and women aged 50 to 79 over 5 years. People with a lipopolysaccharide level of over 50, triple the risk for atherosclerosis during that period of time. Smokers and sex workers with elevated lipopolysaccharide had 13-fold risk in heart disease and stroke, and that is because of changes in the microbiota, activation of innate immunity, and the production of lipopolysaccharide, which in turn, as an endotoxin, is directly damaging to the endothelial lining. So here we have a model of Triad 2 impacting Triad 3, and there's a growing recognition that the gut-related inflammation is a major engine for heart disease. Endotoxemia and diabetes risk, 537 subjects with prevalent diabetes. Mean serum endotoxin levels statistically higher. Their endotoxin score correlated with elevated CRP, cholesterol, triglycerides, and lowered HDL. And so, again, this notion that high LPS in the setting of diabetes also correlated with cardiovascular risk factors. And so as endotoxin activity increases, we see increasing risk for metabolic syndrome. Again, if inflammation is an underlying driver with disruption of insulin signaling, elevation of cortisol, diminishment of T3 receptor activity, so there's this sort of impact of gut inflammation on Triad 1, and therefore this kind of metabolic relationship that's underlying obesity and the predisposition towards diabetes and heart disease. So here are all of the supplements that go along with gut immune brain. And we will go over most of these in our progressions from early imbalances to mid and late stage imbalances in gut immune brain. This is an expanded list, obviously, from what we encountered in Triad 1, but we need all of these tools at our disposal to begin to re-regulate this particular triad. So in the early stage of functional disturbance of Triad 2, which would be a gut-brain pathology, usually there is a symptomatic presentation of changes, but not so much a measurable alteration in key areas within this triad. What you'll typically see in patients is just a direct disturbance of the gut-brain relationship. So they may have irritable mood, poor memory and focus, psychosocial stress, alternating constipation, diarrhea, bloating, maldigestion, cramping, possible reflux or undigested food, but no signs of local or systemic symptoms of inflammation, and no real recognition of food sensitivities, at least just yet. So this is your depressed, irritable bowel patient. What might you see in measured markers? Not much. Normal comprehensive panel, maybe some candida markers, nothing really occurring within the immune system. Maybe there's an elevated cortisol or depressed serotonin. But that's about it. This is really sort of a descriptive, symptomatic, functional imbalance. The initial stage really of gut immune brain pathology restricted to just the gut brain axis. So Sarah W. is our archetype patient in this regard. She's a 27-year-old law student who's driven to succeed. She's been under stress to follow in the footsteps of her father, a well-known federal judge, was a competitive athlete in high school, used to winning no matter what, had recurrent ear infections as a child, but no other physical issues except occasional sinus congestion. She notes growing stomach discomfort and needs to sit near the back of the classroom if the urge strikes. Her mood swings occasionally, and she feels a growing loss of control, but needs to focus on making law review. So, what does she look like in terms of her symptoms and labs? She does have a history of antibiotic use and some recurrent sinus congestion. She's under a significant amount of stress, and she's beginning to express some functional disturbances here in terms of her mood as well as constipation and diarrhea. In terms of measurements, you might see an elevated cortisol, but really nothing else, maybe some candida-related symptoms. So this is someone who is activating Triad 1, mediated through stress. So we know that her immune system will be somewhat suppressed. We know that there'll be diminishment of T3 and a developing insulin resistance. But at the same time, that elevated cortisol will have a direct impact on the gut. Recall histamine release, sympathetic tone activity, predisposition to leaky gut, as well as activation of indolamine. So tryptophan metabolism will be shunting towards quinolinic acid. It's that neurodegenerative model of depression. So she certainly can have spasticity in the gut as well as alterations in her mood, but really there's nothing much to measure except you might capture the stress that she's under. And remember, she's beginning to break down these functional relationships in the sense that this is the system that's supposed to keep her safe and secure in the world, but it's becoming unpredictable. Her mood is a little unpredictable. Her gut is a little unpredictable. It's being mediated through the stress response. And so, it's that disruption of the stability of gut immune brain where she's not as safe in the world as she used to be. So what do we do with someone like her? Well, you want to open her detox pathways, eliminate any potential for yeast and reduce that acetaldehyde, restore normal flora and digestion, decrease any suspected inflammation. Remember, if she goes from elevated stress to chronic stress and she flattens her cortisol curve, she can flip in terms of her autoimmune predisposition. Just in the same way that we had that model in Triad 1, so too can we have that in Triad 2. At the same time, you also have to give attention to her mood and manage that stress response and ensure adequate sleep to sedate that neuroexcitation. So dietary considerations, we're now focusing not so much on carbohydrate intolerance of Triad 1, but we're moving into, well, how do we further personalize a regimen? And that means we have to consider any underlying food sensitivities. You may want to start with just removing gluten and dairy from the diet as an initial intervention, or consider just running an elimination diet program. That's how the metabolic code diet is established, where we remove the common triggers and be able to reintroduce those foods over time and assess whether or not there is a potential problem. So how do we detoxify the liver with her? Well, it's important to get the liver moving again because as imbalances are building in the digestive tract, we see reduction of glutathione, potential expression of lipopolysaccharides or acetaldehyde, which impairs glutathione pools. So we need to help her a little bit in this regard. You can choose milk thistle 2 to 3 times a day, or even artichoke, which is a wonderful choleretic, to get the gallbladder moving again. It's very much underutilized, which can be done 1 capsule 2 to 3 times per day. So how do we restore normal gut flora? There's a variety of good probiotics that are on the market. You can choose a basic probiotic, 1 to 2 caps daily. I like Floramend, which is out of Thorne. I also like Vinco's probiotic, all of which are, heat stable, and relatively inexpensive, which is good to, if they're a frequent traveler. There are also newer probiotics on the market out of Metagenics that help seal up leaky gut, for example. Um, and there's even one called Reg Active, which has been shown to induce glutathione production. So there are a lot of choices, but if you have an individual who's has a significant colitis, I tend to reach for Dr. O'Hara's probiotic, which is a lactic acid fermented. It's relatively expensive, but very, very good at reducing significant inflammation in the digestive tract. You have to take a fair amount to induce that, but it's very good in that regard. Key concept, you want to rotate probiotics to introduce new strains to ensure a, uh, a nourishing of the complexity of the microbiota. For Candida, if you're suspicious, if they have a history of antibiotic use or significant stress, or they're expressing symptoms of yeast overgrowth, whether it's foggy thinking, fatigue, achy joints, skin rashes, athlete's foot, recurrent yeast infections. I like cat's claw. This is an herb from South America. It's a wonderful anti-inflammatory, antimicrobial, and very good for getting rid of yeast. You can do 1,000 milligrams 2 to 3 times per day for 8 weeks or until improvement up to 6 months. If there's a viral component or you need to switch from cat's claw after 6 months, you can switch to plant tannins, 400 milligrams, 1 to 2 capsules, 2 to 3 times per day. If they're salicylate sensitive, you can also do caprylic acid, 600 to 1,200 milligrams, 3 times a day. If there's moderate to severe yeast, a history of sinus symptoms, or a coated tongue, you can always prescribe nystatin, 1 million units twice a day for 3 months. And that's if you can prescribe it. If not, I think cat's claw usually is quite good in this regard. Are they on a proton pump inhibitor? Meaning that they've been diagnosed with reflux disease, and we know that PPIs will reduce stomach acid production, but in turn also decrease the body's ability to digest food. And so if there's undigested food in the stool, you want to put them on enzymes. If they're having undigested food in the stool and they're not on a PPI, you can always add an enzyme with hydrochloric acid. If H. pylori is present, you can also add mastic gum. Mastic gum actually comes from trees, and it's a resin that is very good at healing ulcers in the stomach. You need at least 3 grams per day of mastic gum. A key concept, you want to wean PPIs over 2 months to avoid rebound symptoms. Because you'll get an overactivation of the parietal cells in the stomach. Key concept, I've talked about this sort of indirectly, but it turns out that you can measure these elements of digestive function, which I think are actually very important. So zonulin, which is part of the tight junction complex in the gut. So if you want to understand whether or not a patient has leaky gut, you can assess for zonulin levels. You can also measure DAO. This is diamine oxidase. Diamine oxidase is the enzyme that breaks down histamine. And when individuals have low diamine oxidase activity, they have an excess of histamine production in the gut, which predisposes them to leaky gut as well. Stress can further diminish DAO levels too, and so it's really important to know whether or not they have excess histamine, because then you need to give histamine blockers to help restore normal gut function. And then finally, lipopolysaccharides. Lipopolysaccharides, as I mentioned, are a key factor as an endotoxin, which can damage the brain and the heart and other vital organs. All are key targets for gut permeability. So how do you begin the repair process if there are symptoms or signs of inflammation? You can add zinc carnosine 2 taps twice a day if their differential is less than 7, What do I mean by that? Well, the differential is a summation of the percent of monocytes, eosinophils, and basophils. And you can add the percent up on the CBC differential. If the percentage is less than 7 and they have mild symptoms, you can do zinc carnosine. Zinc carnosine is a product that was developed in Japan many years ago as an alternative to Prilosec and Zantac for reflux disease. It induces healing along the gut lining um, and is a wonderful alternative to the prescribed medications. If their differential is less than 7 but they have moderate symptoms, you may want to add some glutamine, 1 scoop twice a day. Glutamine is a substrate for the lining of the digestive tract, and it helps heal enterocytes. So glutamine is typically a standard with regard to improving gut permeability because it induces repair of the enterocytes of the digestive tract. So this is a nice combination of zinc carnosine and glutamine when there are signs of spasticity or inflammation in the gut. So at a follow-up visit, if symptoms or signs are resolving, great, you continue the regimen. If not, you can always add some aloe or deglycerinated licorice, 1 scoop twice a day. This is a combination product called GI Benefits from Da Vinci, and you may want to check IgG complement food panel to ensure that there's no food sensitivities that are underlying the prolonged symptoms that just aren't responding to a simple regimen of probiotics, cleaning up yeast, and healing the gut lining with some zinc carnosine or even glutamine alone. Is there cramping? If yes, you may want to give tryptophan, 500 milligrams, 1 to 2 caps twice a day in the setting of low mood. So the reason why we put this in here is that you may want to support the mood with tryptophan or 5-HTP, both of which are precursors to serotonin. But it turns out that 5-HTP in particular has a side effect of inducing cramping in the gut because it raises serotonin directly. So you may want to switch to tryptophan, 500 milligrams. Tryptophan can be a little more sedating, though, than 5-HTP. You can always add some St. John's wort, 300 milligrams 3 times a day if they meet criteria for depression. But St. John's wort, you should be aware, has a variety of issues with liver metabolism, and so I tend not to use it in my practice. I often reach for other techniques to help modulate the mood, such as 5-HTP or tryptophan. Key concept, you want to check the MTHFR gene. This is the methyl tetrahydrofolate reductase gene. This is responsible for methylation, and methylation is very simply a tagging system of attaching a methyl group to various substrates or substances in the body. And some people are born with impaired ability to methylate. When that occurs, certain bodily processes are compromised, including the brain's ability to recognize serotonin and dopamine. So sometimes you want to give methyl donors if the individual has been shown to be a poor methylator. The data is very mixed in this regard about how much premethylated B vitamins, for example, to give. Methylfolate in particular, the data is anywhere from 1 milligram to 15 milligrams. I tend to be in the 1 to 6 milligram range if they're an impaired methylator, whether they have one SNP that's been altered, so a heterozygous abnormality, or if they're homozygous. So they have 2 SNPs. So how do we manage the stress response? If they have elevated daytime cortisol, it's Magnolian philodendron, meaning Relora, 1 capsule 3 times a day, or holy basil, 1 capsule 2 to 3 times per day. The holy basil is particularly good with stress and irritable bowel because it's so calming to the digestive tract. How do we manage their sleep? Do they have difficulty falling or staying asleep? If yes, you can do melatonin. There's recent research to suggest that dosing above 3 milligrams is fine. and sometimes patients will need significant melatonin administration for 2 to 3 weeks to get them to sleep, especially if they have very high cortisol levels in the evening. And what you're trying to do is induce deep sleep by giving the right balance of melatonin to cortisol. You don't have to give it for too long, just long enough for them to start sleeping deeply, and then you can reduce the dose. There are some studies that are giving 100 to 500 milligrams of melatonin and titrating down. The dosing regimen for melatonin is all over the map right now, anywhere from a half milligram to hundreds of times of that. If they're continuing to have sleep problems, you can always add in Magnolia and Ziziphus, which is the sister product to Relora called Sedatol, 1 to 2 capsules at night, or a phenyl GABA. This is a phenylated GABA, which crosses the blood-brain barrier. You can do 2 to 3 capsules of that at night. That runs under the brand name of Cavanase from Neuroscience. Either one or both of those are very good at inducing sleep, in addition to melatonin and even holy basil or theanine. So what would you do for someone like Sarah, who's our functional early stage gut immune brain patient? You want to get her on a probiotic, some digestive enzymes, maybe clear up some underlying candida because she's been on antibiotics in the past, and some zinc carnosine to heal her gut lining. And then also we need to modulate her mood because she's under significant amounts of stress. So a Magnolian philodendron such as Relora, maybe some tryptophan for serotonin support, and ensuring that she's sleeping well at night with a little bit of melatonin, and even Magnolian Ziziphus, which is the Sedatol, 1 to 2 capsules. So this is a nice direct regimen that honors the relationship between the gut and the brain. But this pathology can deepen and worsen, and you can have individuals that are reaching into the immune system and they're developing food intolerances, signs of inflammation such as muscle and joint pain, and even recurrent infections. So these individuals then may also have significant depression, anxiety, stressors, addictions, pain-related syndromes. This is your true chronic fatigue fibromyalgia patient who's much harder to treat. So what do we see on measured labs? We may have a normal comprehensive panel or CBC, maybe the presence of candida, but now they're beginning to develop food sensitivities because of their ongoing stress and inflammation. Their white blood cell differential is above 7, so this is again the summation of the percent of monocytes, eosinophils, and basophils. They may have a genetic predisposition to gluten. There could be exposures to known biological toxins like mold or chronic infections, as well as chemicals and heavy metals. We may see an abnormal cortisol curve, so now they're flipping from a high cortisol to a low cortisol, and now they may also have a presence of a heterozygous MTHFR, so they need some methylation support. So what does this patient look like? This is Cecilia. She's our 49-year-old divorced mother of 3. She runs her own cleaning service for the past 15 years. She smokes 2 packs per day, eats on the go, and her only consistent vegetable is ketchup. Work is growing very difficult due to chronic aches and pains, but what choice does she have? She has to take ibuprofen alternating with acetaminophen with codeine just to get through the day. Her digestion is a mess, and she lives on Tums. She admits to depression and very poor sleep, but her citalopram and zolpidem, meaning her Celexa and Ambien, barely work anymore, and she wants to know if you can place her on disability. So this is someone who's very typical as a patient who might present to an integrated practice. She's depressed, she's tired, she's inflamed, she's in pain, she's on a number of medications, and she really wants your help, but she just doesn't know what to do. So she's divorced and stressed, she's had poor sleep and persistent pain with known toxic exposures. So what might her labs look like? Well, she may have a normal comprehensive panel, presence of candida markers, which isn't surprising. Now her gut is showing some inflammation because her white blood cell differential is trending above 7. She could be predisposed to gluten. She's got known lead and cadmium exposures, as well as the presence of food sensitivities because of developing leakiness in her gut. We will deal with the toxic exposures of cadmium and lead when we get to Triad 4. She may have an abnormal cortisol curve because she's more inflamed, which makes sense, which means that she's going to have a treatment-resistant depression, greater brain-related changes, increased stress and sleep disturbance as she dysregulates her sleep-wake cycle, and she's got some methylation challenges. So what do you need to do for her? Well, certainly we need to work on the gut to open detox pathways, eliminate yeast, and restore normal flora and digestion. The key, though, is modulating her immune system by decreasing inflammation, which can be done through food sensitivities and draining toxins, as well as treating her mood disorders and addressing sleep and stress. So patient is likely food sensitivities due to known gut permeability. We want to remove wheat and dairy from the diet as initial intervention. Consider IgG food testing. We can achieve this by beginning by detoxifying her liver through giving milk thistle, which raises glutathione in both the liver and the pancreas. So actually, milk thistle has been shown to help reduce insulin resistance and improve beta cell production of insulin. We want to restore normal gut flora, as I mentioned before, get her on a good basic probiotic. Dosing is at least 1 billion CFU. A lot of individual capsules are 10 billion and above, but more and more we'll be seeing probiotics hit the market that have specific activity. In a patient like her, I might choose something like the Reg Active because it increases glutathione production, which she clearly needs to be detoxified. I don't think she needs something like a Dr. O'Hara with the lactic acid. She either needs a good general probiotic or something like Reg Active. She probably needs a bowel regimen to clean up candida, given all the stress that she's been under in chemical exposures. I probably would choose cat's claw with her. If she has reflux or on a PPI, remember digestive enzymes, and also consider how PPIs may induce loss of key nutrients, magnesium, vitamin D, calcium, protein, and B12. So consider replacing those too. We have to manage her inflammation, and so again, her diff was over 7, which means that we do want to get her on a cat's claw, 1,000 milligrams 3 times a day for a week, and then twice a day for 4 months. Presence of food allergies or sensitivities, we need to begin modulating the immune system to make her less reactive and build immune tolerance. So IgG powder has been shown to do just that because it helps to reset antigen-presenting cells and make the body less reactive and autoimmune, as well as just decrease inflammation in general. So IgG powder works quite well in this regard. You can do purified egg immunoglobulin, or you can do colostrum. The problem with these are that, because they're either dairy-derived or egg-derived, some people have food sensitivities. But if it's not a significant dairy allergy, sometimes IgG powder or colostrum, in fact, helps to improve a dairy sensitivity. So it's always worth a try. I like IgG powder quite a bit in this setting because it's so good at inducing a normal immune response and resetting that allergic and even autoimmune response. You also want to do some GI tract repair. So if they have symptoms or signs of inflammation, if the symptoms are mild and their diff is less than 7, zinc carnosine. If the diff is over 7 or moderate symptoms, you want to add glutamine and aloe. And there's a number of nice products on the market that help to heal the gut lining between glutamine, aloe, and zinc carnosine. What do we do about her mood? Again, tryptophan if there's some GI cramping, if not, 5-HTP. Key concept, consider some methylfolate support, which will help with her mood as well, and modulate her immune system. But again, the dosing is all over the map. Once again, I tend to recommend 1 to 6 milligrams of methylfolate. In terms of managing anxiety with GI inflammation, phenyl-GABA, which is very good at decreasing anxiety, or theanine, which is a green tea extract. We've mentioned this for Triad 1. And you can do 100 to even 400 milligrams of theanine, 1 to 2 capsules, several times a day. I like theanine quite a bit in this regard. It's less sedating than the phenyl-GABA. Phenyl-GABA is probably better in the evening for sleep, and theanine is good for anxiety during the day. It's safe in children and adults. Is there a presence of anxiety and irritable bowel? Holy basil, once again, is wonderful in this regard. 400 milligrams, 1 to 2 caps 3 times a day. Elevated daytime cortisol, Relora. You can always add some phosphorylated serine as well, which blocks cortisol's impact on the brain. Elevated evening cortisol, again, phosphorylated serine or GABA. Key concept, this is a unique combination. If irritable bowel and fibromyalgia, then you want to start RG3 with nicotinamide, 1 to 2 sprays per nostril twice a day to protect the brain. RG3 is a ginseng extract, which is very neuroprotective and quite unique in the way that it induces support for the hippocampus in particular. Nicotinamide riboside, which can be taken orally or by compounded nasal spray, improves NAD pools in the brain. This has been widely studied at Harvard. This is why we talked about acetaldehyde and its offsetting of the NADH-NAD ratio, because there are a variety of ways that NAD is lost in the brain in terms of lowered ATP production, but nicotinamide is what replaces or induces NAD positive production. And so nicotinamide is a B vitamin derivative, which has been shown in a variety of studies to help improve cognition and memory. So we like this combination of RG3 and nicotinamide. Now, this is something that is compounded and therefore has to be prescribed. They're both 2 milligrams and can be compounded through Ray Solano's pharmacy in Texas, which is called specialty compounding. And it's really worthwhile trying because it's so effective at protecting the brain against stress, decreasing pain, and improving memory. So in terms of managing sleep, is there pain and sleep disturbance? We like to use a glandular extract called neuromedulla. Neuromedulla helps to sedate the pain centers in the brain and improve sleep. It's a glandular that specifically targets the hippocampus and the hypothalamus. In 2 weeks, if they're still not sleeping, you can always add some magnolia and ziziphus, which is Sedatal, as well as melatonin. So what would you do for someone like Cecilia? You want to detoxify her gut, and that means milk thistle, maybe a lactic acid fermented probiotic, or a reg active to raise glutathione, some digestive enzymes, and zinc carnosine. In terms of her mood, you have a variety of treatment options. I may reach for the RG3 nicotinamide, the neuromedulla, theanine during the day, and a methylfolate. But the main focus is on what do we do for her immune system. I think IgG powder is an excellent choice, as well as glutamine aloe and cat's claw, as well as moving down to Triad 4 in terms of detoxifying her. Now, you can start that by raising glutathione, but you'll have to do more than that over time. But this treatment is really oriented towards decreasing inflammation and supporting her mood and gut. And so these are nice choices in that regard. And then our final gut immune brain pathology is when there's known autoimmune diseases, truly impaired immunity, significant depression, anxiety, persistent fatigue, and brain fog. So this is someone who's very, very sick. So in terms of their markers, you may want to measure DAO, lipopolysaccharide, zonulin, and histamine. In terms of immune activity, I think the keys here are not only food sensitivities and markers of autoimmunity, but you may want to look into their innate immune system with TGF-beta1, C4a, C3a, VEGF, and MMP9, as well as consider any sort of measurable biotoxins like chronic infections such as Lyme disease or tick-borne illnesses, as well as the potential for mold exposure and viruses. And as far as brain pathology goes, they may have an abnormal cortisol curve, an elevated beta 2 microglobulin, which indicates blood brain barrier breakdown, positive double SNP on MTHFR, but also some additional changes in neuropeptides and neurohormones, such as melanocyte stimulating hormone, VIP, TGF beta 1, and C4A. If you're interested in those markers in particular, I recommend going to the website survivingmold.com, which begins to articulate all of those key factors that underlie innate immune activation, which is termed chronic inflammatory response syndrome. So these markers that I'm mentioning, you can read in greater detail on the Surviving Mold website, and it will go into the mechanisms by which these markers become abnormal and then what to do about it. I also order NeuroQuant, which is a very specialized brain MRI, which can show architectural changes in the brain as a consequence of neuroinflammation. And then also there's something called the visual contrast study, which you can also read about on the Surviving Mold website. I won't go into any great detail here because this is a more progressive thinking for gut immune brain. I wanted to list them here to show you where they fit. And if you're interested, you can start reading about them on your own time. We will return to this later in the course as a deeper expression of a gut immune brain pathology. So WCW, 22-year-old male with Crohn's disease, was a preemie admitted to the ICU at birth, underwent sepsis rule-out, early problems with feeding, reflux until 2 years old, recurring pharyngitis with tonsils, removed by age 10, underwent major stressor of car accident when learning to drive, no head trauma or loss of consciousness, had to repeat sophomore year of high school. Since the accident, he's never felt right. Then one day he noted blood in his stools. So he's a expression of sort of a fully blown gut immune brain because now he's autoimmune. You may see elevated calprotectin, which goes with inflammatory bowel disease, significant food sensitivities, a flattened cortisol curve, elevated beta 2 microglobulin. So what do you do with him? We still want to focus on restoring as much normal gut function as possible, enhanced use of anti-inflammatories and immunomodulators, aggressive elimination of food allergies and toxins, and address sleep and stress. So patient has food sensitivities. You want to consider the specific carbohydrate diet or caveman diet, and then IgG food panel. I like the ELISA ACT test, as well as MRT. And then also Dunwoody Labs has a very nice panel too. Those are three that I think are all quite good. Again, detoxify the liver, especially because this is a patient who's going to be on a lot of medications. I think this is someone who really needs the lactic acid fermented probiotic to try and get his gut under good control. You have to do a titrated regimen. Again, this is Dr. Ohira's. He certainly has inflammation, and I like cat's claw in this regard. There can be significant GI inflammation. So again, cat's claw. If there's presence of food sensitivities, he'll need quite a bit of IgG powder, 2 tablespoons 4 times a day, and or colostrum. Is there presence of an autoimmune disorder? If yes, I like Sterilins. This goes under the brand name Moducare. Moducare is something that we've covered, but helps to modulate the immune system to become less autoimmune. It's 3 caps twice a day for 60 days and 3 caps daily. This is a very good product in combination with the IgG powder as you're trying to restore more immune tolerance. You may also want to consider a vitamin C flush. I would suggest going to PERQUE, P-E-R-Q-U-E, vitamin C cleanse or flush, and you can see how you can significantly dose vitamin C orally through a titrated regimen to improve immune tolerance and antioxidant status. Key concept, use Boswellia, 400 milligrams, 2 caps 3 times a day for 60 days, then 1 cap 3 times a day in patients with inflammatory bowel disease to decrease inflammation. Boswellia is very good in this regard as an anti-inflammatory herb. Major symptoms of inflammation, if yes, which this patient obviously has, he's going to need some glutamine, aloe, and zinc carnosine. Does he have low mood? They often do, so he might need some tryptophan or 5-HTP. Does he feel flat and depressed? He might need some tyrosine as well. We've talked about this for Triad 1. You want to check his MTHFR gene. He might need some significant methylation support, so I might be in the 6 milligram range for him. For anxiety and GI inflammation, again, theanine I think is wonderful during the day. Is there elevated daytime cortisol? Magnolia and philodendron, we know this is Relora. Does he need stress support? We saw this from Triad 1. He probably needs an adaptogen of some sort. He may in fact need the RG3. Elevated evening cortisol, phosphorylated serine, or high absorption GABA, which is the phenyl-GABA called cavanase from neuroscience. Pain and sleep disturbance, neuromedulla. Magnolia and ziziphus at night for sleep and melatonin. This is the Setitol product. Toxin management, so presence of autoimmune disease, if yes. At some point you may want to consider heavy metals, chronic infections, mold exposure, and food sensitivities. The mold exposure and chronic infections are the other labs that I mentioned. Again, you may want to go to survivingmold.com and begin reading about the additional strategies that you can begin thinking about. I will cover that in detail in future courses, and certainly food sensitivities. The heavy metals and chemicals we will address as part of Triad 4. If there's a presence of a virus like a reactivated Epstein-Barr virus, CMV, HHV6, HSV1 and 2, olive leaf extract, 3 caps twice a day, is a very good antiviral. Astragalus, 1 cap 3 times a day for immune support. And then you can consider a few others, but I think starting with olive leaf and astragalus is a good way to begin with viruses. You could also consider monolaurin or lauricidin. So in terms of what to do if they have specific autoimmune diseases for rheumatoid arthritis, there's UC2, which is undenatured collagen. This comes from a chicken sternum. It's very good for rebuilding collagen and protecting the joints. You can also do a thymus extract, 2 caps twice a day, which is also very good for the joints. Consider minocycline. There is some data on minocycline, 50 milligrams daily prescribed. Low-dose naltrexone, 1.5 to 4.5 milligrams at night. So low-dose naltrexone is very good at ensuring that MHC class II cells are better able to recognize self from not self. The way low-dose naltrexone is prescribed as a compounded medication is 1.5 milligrams at night for a week, then 3 milligrams at night for a week, then 4.5 milligrams at night for a week. What it does is temporarily suppress endorphins in the brain, and as those endorphin levels climb several hours later, they modulate MHC class II cells in the brain, which improve immune tolerance. And then sialic acid is also very good because sialic acid is a mucin-producing product that helps to protect against the formation of food immune complexes in the gut. So if you're trying to block significant food sensitivities, you can take 2 caps with meals of sialic acid. If they have MS, again, low-dose naltrexone. There is some data on estriol, although 8 milligrams always seem like a lot to me, so I don't recommend it. Krill oil is pretty good as an anti-inflammatory. We put that in there because there's some data. And then again, the sialic acid. And then finally, with Sjogren's syndrome, the sialic acid. So the treatment would really be focused on the bottom box, which is the IgG powder, the cat's claw, Boswellia, sterilins, meaning Moducare, removing of toxins, and then also dealing with their gut and mood. This is a patient who will need significant help with their lactic acid, fermented probiotics, detoxification, immune modulation, and sedating the brain. So you want to make sure that their mood is under control, they're sleeping well at night, you're removing any potential triggers that you can identify in terms of toxins or food sensitivities, and modulating that immune system through the Boswellia, cat's claw, sterilins, and IgG powder. and you'll find that you can often induce these patients to go back into a relatively calm immune state. So that is Triad 2. I know it's more complicated than Triad 1. There's a lot more choices, a lot more complexity. These patients are more complicated in general, but this is a model of how they progress from a functional disturbance to a deep metabolic disturbance. And we've given you some real tools in this regard to help deal with these patients that are very common in our practices, but also a real challenge clinically. So thank you very much for your attention.